Welcome from the Tennessee Heart Health Network Learning Collaborative Series. This session today is entitled A Hands-On Approach to Cardiovascular Disease Risk Management for People Living with Mental Illness and was originally presented on March 30th, 2023. My name is Joel Mars and I'm a professor of clinical pharmacy and translational science with the University of Tennessee Health Science Center College of Pharmacy on our Nashville campus. I practice clinically with the Ascension Medical Group here in Nashville. We have a few learning objectives that we're going to go through in today's session. First, we're going to review some of the key and major recommendations from essential guidelines for the management of common cardiovascular disease and how that applies to patients with mental illness. Secondly, we'll look at a few risk assessment tools in regards to determining patients' requirement for intervention. Thirdly, we'll look at some pharmacologic approaches and how to manage patients with comorbid cardiovascular disease as well as mental illness. And then lastly, we'll talk about some strategies to achieve optimal outcomes in patients with cardiovascular disease and mental illness and discuss some barriers to care. Mental illness, psychiatric medications, and cardiovascular disease is where we're going to first start off and kind of look at the comorbid development of some of these conditions and talk about some of the causality of disorders that present. So one thing that we do know is that mental illness and cardiovascular disease occur concurrently in many patients. Up to 15% of patients with cardiovascular disease and up to 20% of patients who have undergone a coronary artery bypass graft have been shown to have depression. Additionally, patients with severe mental illness are twice as likely to have a cardiovascular-related death compared to those without mental illness. And then thirdly, especially in the heart failure population, we know that patients with comorbid heart failure and depression are more likely to be hospitalized than those without depression. And so it highlights the fact that we need and oftentimes are co-managing patients with both mental illness and cardiovascular disease and needing to think through what is optimal care in regards to both disease states so that we're not necessarily worsening mental illness through the exposure to cardiovascular risk lowering therapy, as well as we're not causing more additional consequences. So mental illness and cardiovascular disease have a few things related to them as it relates to increased prevalence of lifestyle choices that can increase cardiovascular disease. So needing to address, just like we would in a patient population without mental illness, addressing physical inactivity, something to keep in mind, increased weight, especially some of the medications that can be prescribed for patients with mental illness oftentimes have cardiometabolic side effects, and so being cognizant of increased weight. Metabolic syndrome is very prevalent as well, keeping an eye and focus on tobacco cessation, and then additionally substance misuse or abuse, and then lastly medication non-adherence. And so we'll bring into some of these as we get into some of the guideline recommendations and scenarios in the session today. So as I mentioned, mental illness and cardiovascular disease coexist in many patients. Mental illness has been associated with cardiovascular diseases, and so we do have known associations with patients that have mood disorders, anxiety, PTSD, chronic stress, and substance use disorders. And then we do know that there are cardiovascular effects of mental illness. And so in patients, we can see some patients will have an elevated heart rate, and this oftentimes is related to anxiety disorders in many instances, increased blood pressure. You can see that as well. You can see decreased cardiac blood flow and increased cortisol levels, which can lead to further cardiovascular disease or the development of cardiovascular disease to begin with. So wanted to highlight some of the common classes of psychiatric medications and cardiovascular effects that we should be aware of. As in some instances we're able to monitor these, in some instances we're able to avoid or modify therapy to minimize some of these effects. Atypical antipsychotics and antipsychotics in general, we know have a higher risk of patients developing metabolic syndrome, and ultimately can lead to increased risk of atherosclerotic cardiovascular disease or ASCVD. A couple of the agents that have the highest risk are clozapine and olanzapine, and in many patients those are indicated therapies and maybe have the patient controlled from their mental illness side of things, but being cognizant of these can lead to more cardiovascular risks associated, as we can see, increased metabolic side effects from glucose changes to cholesterol changes to weight changes in many patients, where we do have some antipsychotics, especially ziprasidone, haloperidol, lorazepam, aripiprazole, acinapine, are the ones that have the lowest risk. And so it brings into light the discussion and assessment of switching patients sometimes if they do develop some of these cardiovascular events. As it relates to mirtazapine, this has been shown to develop patients develop orthostatic hypotension in some instances, and so if patients have a risk of low blood pressure or kind of run low, this may be something to be more cognizant of. SNRIs, we know, have been associated with increased blood pressure. Generally, if patients have controlled blood pressure, this is not a major issue, but those with uncontrolled blood pressure, this can worsen their blood pressure elevations. You can see this tends to occur at higher doses, and so, for example, venlafaxine at doses above 200 milligrams is where we've seen the most pronounced blood pressure increases in patients. From an SSRI standpoint, being cognizant that antiplatelet activity can be increased, and so when combined with other agents that increase bleeding risk, just being aware of that combination can put patients at a higher bleeding risk. Trazodone at higher doses, we have seen arrhythmias, and then we know TCAs at higher doses can cause a variety of cardiotoxicities. If you look across the landscape of antidepressants and cardiovascular safety, fortunately, we have a number of agents that have actually demonstrated that they're safe to use from a treatment of mental health and depression symptoms with comorbid cardiovascular disease. So in the post-MI population, we have good data across the board with SSRIs, as well as bupropion and mirtazapine in this population. From a coronary artery disease standpoint, we have specific data with citalopram and paroxetine, but likely this is a class effect with SSRIs and would be safe to use. From a stroke standpoint, we have limited data, and of the data that we do have some safety data with SSRIs, but it's not as strong as the data in the post-MI population, for example. And then fortunately, since we know that comorbid depression with heart failure is common, we do have safety data with bupropion as well as SSRIs. As I mentioned before, we have some antipsychotic agents that are more metabolic in nature from a side effect profile than others. I previously mentioned clozapine and olanzapine, those are the highest, and so that holds true with weight gain as well. And so as you can see here, clozapine and olanzapine lead the list as the highest agents with the propensity to cause weight gain. We have a few in the middle when you're looking at atypical antipsychotics. You see quetiapine, risperidone are more moderate, and then as you go down the list, we have a number that are a lower risk. And so it's assessing the patient at baseline. Are they overweight, obese at baseline before exposure to some of these agents? And then once exposed, have we seen weight gain with them? And do we need to modify therapy to help minimize some of that effect? Weight gain typically occurs around the dose initiation phase with these agents, but can occur later during exposure, especially if you're titrating to higher doses, and so oftentimes is dose dependent in nature. So from a monitoring standpoint, with antipsychotics for some of these metabolic side effects, it's important to get baseline assessments, as we talked about, from a blood pressure standpoint, from a glucose standpoint, with either fasting plasma glucose and or A1C, getting lipids and weight at baseline. And a lot of the chronic assessments are going to be assessing especially weight at roughly basically monthly intervals initially for the first 3 months, and then probably shifting to kind of Q3-month intervals thereafter. But continuing to assess any changes in blood pressure, glucose, and lipids at least after the first 3 months of exposure, and then can, depending on elevations or lack thereof, can switch more to kind of an every 3 to 6 month follow-up. So recommendations for patients for mental illness and cardiovascular disease. So would recommend incorporating cardiovascular disease risk assessment in patients with mental illness, so that when they're coming in for visits, making sure we're getting blood pressures, heart rates, weights, doing those baseline, and then sequential testing of laboratory values to assess any potential cardiometabolic risks there. And then in patients with severe mental illness and those with cardiovascular disease or risk factors, consider switching to agents that maybe have a lower risk, especially if patients are stable, but always evaluating kind of the risk benefit there as it relates to their therapy. Carefully screening for drug-drug interactions as it relates to psychiatric medications and cardiovascular medications, as many of them go through the CYP3 450 system, and making sure we're not seeing any drug interactions that would be causing worse cardiovascular disease or potential other side effects. And then long-term, just monitoring the risks and adjusting medications accordingly, as we know some of these medications can cause increased risk over time. So that leads us to the next section, which is key guidelines and assessment tools. So we're first going to start off with treatment approaches and clinical pearls and primary prevention, and then we'll delve into secondary prevention here in a little bit. So there's a large landscape of guidelines out there that address primary prevention of cardiovascular disease, and not all of these are specific to patients with mental illness. Some of them specifically call out patients with mental illness within their guideline, and some don't. But overall, we'll kind of review the big picture pieces that would apply to patients with or without mental illness, and then some of the kind of specific pieces that do call out addressing cardiovascular disease prevention in those with mental illness. And so we'll review some of the major hypertension guidelines, cholesterol guidelines. We'll talk about glycemic control from the ADA recommendations, and then delve into some of the risk assessment pieces as well. So first off, let's just look at assessing risk. And so the general recommendation from the American College of Cardiology and the American Heart Association, based on the most recent cardiovascular cholesterol guidelines that are available, is assessing risk based on this pooled cohort equation to look at risk of ASCVD events over a 10-year period of time. And so what this tool does is it allows you to input a variety of patient characteristics or parameters, and it will predict or assess what the potential risk of having a future fatal or non-fatal myocardial infarction or stroke is over a 10-year period of time. As you can see here, they look at a number of factors of biological sex, they look at age, total cholesterol, as well as HDL cholesterol, systolic blood pressure and whether you're treated or not, smoking, whether you have a history of that or not, race. They do categorize race within 3 categories of white, other, and African American, and then diabetes, whether you have the presence of diabetes or not. Some of the race pieces that they've built this off a few different databases to use this equation, and so there haven't been a lot of other high numbers of other races that they were able to justify or validate within their algorithm. So as we jump into management of patients with cardiovascular disease and mental illness, I did want to highlight the SNR piece. And I did talk about this previously, and so we do have some analyses that have looked at SNRI exposure and increases. And as you can see here in this first bullet, one meta-analysis demonstrated only a difference of 1.5 millimeters of mercury elevation in blood pressure with exposure to SNRIs. There are a few other analyses that have looked at this as well, and in these analyses it showed in those that got exposed to venlafaxine, and one analysis showed a 9% increase in blood pressure at higher doses. And so this one specifically looked at doses above 300 milligrams. There was a second one that looked at doses above 200. But I would say at higher doses is where you're going to need to have a little bit more focus on this, and probably where you can see somewhere between a 5 to 10% elevation in blood pressure at those higher doses. So let's jump into hypertension management as it relates to preventing cardiovascular disease. And so the last update from the American College of Cardiology and the American Heart Association was in 2017 from a guideline standpoint. And they basically articulate that there are blood pressure thresholds and there are blood pressure goals. As you can see here, the threshold for most patients is when your systolic is above 130 and your diastolic is above 80. This holds true for those that have established clinical cardiovascular disease, or they have that estimated 10-year risk greater than or equal to 10%. So we know that that group's a little bit higher risk, and so a threshold of treatment at greater than 130 over 80 and trying to target their goal less than 130 over 80. They're in patients that don't have established cardiovascular disease, or if they have a risk score less than 10%, that threshold's a little bit higher before you would initiate therapy, and so greater than 140 over 90 and a goal of less than 130 over 80. And then in older individuals, they call out if your systolic's above 130 that you should treat those patients as well. We know that this is not the only guideline that exists, and so there are some more recent guidelines from AAFP that aren't as aggressive as these goals and have a little bit less aggressive goal of 140 over 90 for most, and those that are very high risk, less than 135 over 85. But then when you get into some of the subpopulations that we know have increased cardiovascular disease risk, and across the board you can essentially see that whether you have diabetes or chronic kidney disease or heart failure or stable ischemic heart disease, these are patients that we're going to be aggressive at managing them, especially if they have comorbid mental illness, because we know oftentimes their risk of cardiovascular disease is even higher in some instances. The only unique portion on this slide is that folks that have our secondary stroke prevention, the threshold to treat their blood pressure is a little bit higher at that 140 over 90. And as I mentioned, different guidelines have different recommendations. And so one thing that did happen in 2023 was the ADA actually aligned their blood pressure goals based on the evidence with the recommendations from ACC/AHA. And so they actually have the same goal, less than 130 over 80 for patients with diabetes. Uniquely in those with chronic kidney disease, the KDIGO group, specific to the kidney disease population, recommends a systolic goal of less than 120 if tolerated. And so trying to get those to less than 130 over 80 for sure, and potentially less than 120 from a systolic standpoint. And then, as I mentioned, the AAFP 2022 guidelines recommended a goal of less than 140 over 90 for most adults. And you could be more aggressive at those if they are higher risk and have established cardiovascular disease. The other thing to keep in mind with hypertension management from a primary prevention as well as secondary prevention standpoint is those agents that have compelling indications based on clinical condition. And so being familiar with those and which agents we should be using, because depending on their medications we're using for their mental illness treatment, there may be interactions. And so one example that comes up is with RAS blockers, so ACEs and ARBs. and the interaction with mood stabilizers like lithium, you'd want to avoid that combination. And so discussing those risk benefits of there might be first line therapy, but based on drug interactions, you might need to use other therapies based on their clinical condition and comorbidities. So that leads us to the 2018 American Heart Association, American College of Cardiology, and multi-society guidelines for management of cholesterol. So I've reproduced the primary prevention of ASCVD algorithm from these guidelines, so we can kind of walk through this today. There are kind of three buckets here. Those that present on the top far right here with an elevated LDL cholesterol greater than 190. Those are considered high risk based on that baseline value being so high and are indicated for high intensity statins. This is a group it's designed to help try to identify those that have familial hypercholesterolemia. And then there's the group of diabetic patients just below that. And so anyone between the ages of 40 and 75 with diabetes is considered moderate risk, and so would be indicated for a moderate intensity statin regardless of what their cholesterol values are. But if they do have multiple additional risk factors or other factors to consider from a cardiovascular disease standpoint, you could consider high intensity statin in those. And then the other big group is those that don't have comorbid diabetes and don't have a baseline LDL greater than 190. For those, then we risk stratify them. And so if they're between the ages of 40 to 75, we have the ability to use that risk calculator, and depending on the risk calculator score, they either fit into a few categories. So if the risk score over 10 years is greater than 20%, then you'd actually maybe indicated for high intensity statin therapy to reduce their cholesterol greater than 50%. If they fit into the intermediate risk of 7.5 to 19.9%, that's where you would at least initiate a moderate intensity statin therapy and then reassess depending on response to therapy. If they're borderline risk, that's where you can have that patient-focused discussion in regards to risk-benefit, and they could be considered for moderate intensity statin, but that's not necessarily indicated for all patients. And then if they're less than 5%, then emphasizing lifestyle, which should be emphasized for all these patients, but would not be considering pharmacologic therapy for cholesterol lowering in that population. If they're younger, the recommendations for those aged 20 to 39 is to look at their lifetime risk score. And so that's basically a risk score that the tool can calculate, and it looks at your risk over a 30-year period of time. And so you can factor in those parameters of cholesterol values and blood pressure and smoking history and things, and funnel that into the risk scoring tool to evaluate what their lifetime risk might be. So now we're going to transition after we've covered hypertension and cholesterol lowering and kind of risk benefit approaches there to the ADA standards, which are published every January in diabetes care. And so this is a summary table of agents that we now know that the landscape of cardiovascular prevention and management with anti-hyperglycemic agents has increased dramatically over the last 5 years. And so have just highlighted some of those changes. And so I think the nice thing about the ADA standards is they have these nice tables that look at a number of parameters as it relates to drug selection. And so anything from efficacy, so how effective are they at lowering A1C and improving glucose control? Do they have risk of hypoglycemia? Do they have weight changes? And so we talked about having cardiometabolic disease and comorbid mental illness, and exposure to some mental illness medications can increase your weight, as well as some of your other cardiovascular parameter risks. And so being cognizant of that. And as we've seen the landscape change with approved weight loss agents, and our GLP-1 receptor agonist group of agents that have demonstrated pretty pronounced weight lowering in those that are obese, in addition to glycemic control is something to factor in. And then in this black box in the middle, you can see those that have cardiovascular effects. So across the board, ASCVD lowering effects. And so we know TZDs, specifically pioglitazone, has demonstrated some benefit, especially post-stroke. And then we have our two big classes where we've seen the most agents demonstrate benefit, and that's our SGLT2 inhibitor class and our GLP-1 receptor agonists, where we've seen a number of agents, as you can see here, show benefit with reducing ASCVD, and then across the board with SGLT2 inhibitors, essentially all of them have demonstrated benefit in heart failure, and then now dapagliflozin and empagliflozin have shown benefit in those even with preserved EF heart failure. And so, depending on the patient's population and comorbid factors, these are things to consider as you're choosing drug selection for patients. One of the unique things with the ADA guidelines that came out earlier this year was they have a specific section on providing diabetes care in patients with serious mental illness. And so they provide an increase, they recommend providing an increased level of support for people with comorbid diabetes and severe mental illness through enhanced monitoring of and assistance with DSM behaviors. They also recommend people prescribing atypical antipsychotic screen for prediabetes and diabetes 4 months after initiation, sooner if clinically indicated, and then annually. And so having that in the forefront of your mind of making sure we're screening for these patients' cardiometabolic risk, and if using second generation antipsychotic medications for adolescents or adults, making sure you're looking at weight, glycemic, and cholesterol changes and monitoring over those time, because we know that those can occur initially, and then they can also occur months to years after being started on therapy. So that leads us next to folks that have secondary prevention. So these are folks that we know already have established cardiovascular disease, and so that could be a history of myocardial infarction, history of stroke, could be established peripheral artery disease, maybe established coronary artery disease, and a history of chronic angina. So these are folks that we already know are high risk, and how do we optimize their care with concurrent mental illness management as well. And so just highlighting some of the guidelines. So there is some overlap with what we talked about for primary prevention as it relates to both hypertension and cholesterol. But we do have some other recommendations for non-statin therapy, especially as we become more aggressive in trying to reduce risk in those that have already had one event, because we know the risk of having another event is very high. So if we jump back to the 2018 AHA-ACC multi-society guidelines for management of blood cholesterol, we have this nice algorithm that highlights kind of the pathway for secondary prevention. So it kind of has two buckets. The first bucket is those that are considered very high risk. And so essentially that's on this right-hand side of this pathway. And those up front should get high intensity statin as the first line approach. And the way a patient would be considered very high risk is so they have one event plus multiple cardiovascular risk factors, or they've had multiple events. And so for many patients, many cardiovascular risk factors led to that first event. And so many of our second prevention ASCVD patients fit into this very high risk bucket. And this is where we get into the idea of thresholds. And so if you follow this right side of the slide pathway, you can see if they're on maximum tolerated statin and their LDL is still above 70, then it's reasonable to add ezetimibe. If you're considering a PCSK9, you generally want to add ezetimibe first. Some of that is because from a more cost-effective approach and accessibility approach, we can see if we can get patients that are under that 70 mark, and then considering a PCSK9. But many patients still, to maximize their lipid-lowering therapy and get to less than 70, might need a high-intensity statin, ezetimibe, plus a PCSK9 inhibitor to get there. And so when these came out in 2018, the cost of PCSK9s was higher than it is today, but still there are some restrictions from an access standpoint, and oftentimes patients need to be trialed on ezetimibe before considering PCSK9s in many patients. If you go down the left-hand side of this pathway, those that aren't very high risk, you still are recommended to start a high-intensity statin. If you're still above that threshold, then you could consider ezetimibe in those patients. And then those that are older in age, so over the age of 75, we just don't have a ton of data as it relates to evaluating this population and risk-benefit. We do know that there is benefit in this population, so recommending at least a moderate intensity statin is reasonable. Or if they're 75 and they turn 76 and they're tolerating therapy, continuing that high intensity statin therapy is appropriate. As I mentioned, those that are considered very high risk, it fits into these kind of two buckets. So having a major cardiovascular event, and if you've had multiple, then you're very high risk, or if you have one major event and you have some high risk conditions. So you're older in age, you have comorbid diabetes, hypertension, CKD, or you're still having LDL above 100 despite maximum tolerated statin and ezetimibe, you could be considered this very high risk as well. And so a number of patients from a secondary prevention standpoint fit into this category. And so last year in 2022, the ACC consensus pathways came out from the American College of Cardiology. And these one pathway specifically looked at non-statin therapy. And so this was specifically looking at those that are very high risk, as this figure here. And so this kind of called out or recommended even becoming more aggressive with lipid-lowering therapy in these very high risk folks. And so trying to achieve more than that 50% LDL reduction, and then setting an LDL threshold of less than 55 on maximum tolerated statin therapy. So if you follow this algorithm down, you're going to see you're still going to evaluate lifestyle modifications in addition to pharmacologic therapy, assessing adherence, risk factors, all of those things, and then trying to maximize their therapy. So getting them on max tolerated and ideally high intensity statin therapy is the goal, and then considering some non-statin therapies. And so this aligns well with the 2018 guidelines. On the left-hand side, we're considering ezetimibe or a PCSK9 inhibitor, but then we have a few other agents that have come to market in the last few years. And so in some patients, you might consider bempedoic acid or inclisiran as additive to those, or as a different option than those. The way this pathway works is generally the left-hand side of this pathway is kind of the first-line agents, where bempedoic acid and inclisiran would be more secondary considerations depending on tolerance, goal achievement, and willingness to use injectables or not in regards to drug therapy. And those that aren't very high risk but still secondary prevention, it has a little bit different pathway and a different threshold. So these still target that less than 70 threshold on maximum tolerated statin therapy, still evaluating the same risk profiles and adherence and side effects, and then kind of looking at kind of in a stepwise fashion of considering ezetimibe first, then considering adding or replacing with a PCSK9 inhibitor, and then considering bempedoic acid or inclisiran. So in our last few slides for the session today, I'm going to cover a few key pieces, I think, as it relates to cardiovascular disease risk assessment, management, and those with serious mental illness. And so Murphy and colleagues highlighted this kind of stepwise approach, which I think highlights some of the key components of the kind of the care continuum for cardiometabolic conditions. And so not forgetting to screen patients with serious mental illness on regular intervals, so at baseline as well as once exposed to certain therapies, and depending on their baseline risks, doing regular interval screening, especially baseline, probably every 3 months, and then every 3 to 6 months thereafter. trying to diagnose cardiometabolic conditions earlier so that we can maximize therapy, modify therapy in regards to minimizing that risk of cardiovascular events, providing lifestyle counseling and promotion of medication adherence, potentially using motivational intervening techniques to improve or help with some of that. And then lastly, creating evidence-based goals and applying those guidelines that we reviewed today to the patient with mental illness, whether they are a primary prevention or a secondary prevention patient. As we all know, there are barriers to care in all populations, but there are some specific barriers to care in those with mental illness that I wanted to highlight. I think these can be looked at in a few different buckets, and so there's those patient level barriers that we need to consider. We know that low socioeconomic status, low educational attainment, unemployment, social isolation, homelessness, criminal justice issues, and substance abuse disorders have all been associated with increased risk of developing cardiometabolic conditions in patients with serious mental illness. And so having that focus on ways we can try to identify as well as work with patients and help with some of these barriers to care will ultimately help us improve reducing that risk of cardiometabolic conditions in those with serious mental illness. From a provider level standpoint, there are a number of challenges. I think one of the key or big challenges here is who provides the physical health care and how is it implemented, are observed from both primary care and psychiatric perspectives. So is there that communication ability pathway between the primary care providers and the psychiatrists, and kind of especially with monitoring, assessment, risks with drug exposure and toxicities, kind of what is that kind of communication pathway. There are different settings where sometimes there are primary care services within a psychiatric clinic and kind of vice versa. There are psychiatric services within primary care, and how to optimize that integration, I think, is key from a risk assessment standpoint for cardiovascular disease in this population at baseline, as well as kind of continued monitoring, especially with drug therapy changes, both from a mental illness standpoint as well as a cardiovascular disease standpoint. And then lastly, from a system level, there can be structural barriers that are disproportionately affect populations with serious mental illness, which likely strongly influence both the prevalence and management of cardiovascular risk factors. And so at the system level, are there things that can be done or identified as potential ways to improve communication and care across the system? So from a strategies to address these barriers, there are a couple buckets that things can fall into. I think there are some organizational of healthcare delivery pieces. And so, as mentioned before, potential to bring physical health services to mental health programs, and then support physical health care clinics within mental health can be potential ways to address some of this cross-management and optimizing care for patients as a whole. And then additionally, strategies to support healthcare providers. Can there be optimization of use of clinical decision support tools? Can they be integrated into your EHR or EMR? And making resources available from optimizing therapy. Sometimes, depending on which EHR you practice in, best practices can be highlighted, or things when lab values come back or drugs are ordered to help optimize monitoring and titrations, and optimizing use, leveraging multidisciplinary teams when possible to help optimize care of patients and access to patients, and then addressing unconscious bias is an important key factor. And so with that, I have highlighted a few additional resources that are available. Some of these I referenced within the slide set as well, but I think if you want further information, some of these do go into these pieces a little bit more in depth, but I appreciate your time listening to and interacting in the session today, and hopefully this was helpful, and look forward to working with you. And if you have questions, feel free to outreach to me directly. I did include my email in one of the first few slides. So if you do have specific questions or want additional information on what was covered, please let me know. And with that, I will conclude the session today. Thank you.